So let's talk about the dying process and the needs of residents who are nearing the end of their life. So death is defined as the final stage of life, and as a nurse aide, you'll need to develop a realistic attitude towards the topic of death to meet the physical and psychological needs of residents and their family as they experience the process. This is also talks about caring for the body following death. So think about what the setting sun is no less beautiful than the rising sun. So if you think about it, everybody is excited at the birth of a child and people are very sad at the death of a loved one. But neither end of that spectrum is any different. It's just a stage that we go through. So psychological changes of the grieving resident. So Elizabeth Kubler-Ross presents 5 stages of grieving. And a couple things to note is not all residents go through all of the stages. Some of them may stay in one stage until death is actually occurring. And sometimes people move back and forth between the stages. And not only does the resident go through the stages, but the family and the friends also go through the varying stages. So we have to understand the stages of grief, and that also will help you, the nurse aide, apply psychological support to residents, family, and their friends. So stage 1, the beginning, is denial. So when we first find out that we're headed towards death, we all deny it. It's a buffer against reality. It is a defense mechanism. And it's an emotional escape hatch. So at this time, during denial, people may request a second opinion. They may not want to discuss death, and they may say things like, this can't be happening to me. We've all heard that. So you need to be prepared to listen as your residents express their feelings, and don't try to sway them. Just listen and hear what they have to say. So then we move on to anger. So anger is bitterness and turmoil and a sense of unfairness. Why did this happen to me? And a lot of times we'll blame everybody but ourselves. Elderly may blame a misdiagnosis. They may blame the caregiver. They may blame a spouse. They may blame everybody other than having the realization that this is just part of living. Dying is part of living. So you have to be very careful not to take things personally. Allow our residents to be frustrated and just listen empathetically. You may not understand what they're going through, but the art of listening is truly an art. Then we go into bargaining, which at this point a lot of times our residents turn to religious and spiritual beliefs. They make promises to God and others, things like, oh my God, if you won't let me die from cancer, then I'll be the best person you've ever known and I will give all of my money to the church. So this is a bargain. Comfort and hope when all seems lost is part of bargaining. Generally, people realize that this won't work, and then frustration and anger will turn into depression. Dear God, if only you cure me from cancer, I will give all of my money to the church. So again, you need to make sure that you listen, reflect on what is said, and be aware of when silence is something that's actually golden, and learning not to speak and be comfortable with the silence and not to actually say anything. Depression. So depression is the belief that hope is lost. People feel this overwhelming sense of despair. They become introverted and withdrawn. They reminisce and review life, thinking about what they did in the past. Sometimes they get very sleepless and they aren't able to sleep. And they reminisce thinking, I wish I would have, I always wanted to, or what would have happened if. So at this point, if your touch is accepted, it can be a very helpful tool for you. Give a light touch to your resident. Understand that they are feeling loss, and don't deny them that death is approaching. Then we move into acceptance. Calm and subdued interest in life. Strive to complete unfinished business. Help loved ones accept the death. And need for others to validate the worth of life that you've had. Sometimes you'll hear residents say, I've had a good life, I'm ready to go. Your presence lets them know that you're not going to desert them and leave them. Listen if they want to talk about their death. So factors that influence residents' and families' attitudes towards death can be personal experiences, the things that you've experienced personally in a death. Were you young the first time that you saw someone who had passed away and they were in their casket? Or have you never seen that? Culture oftentimes, a lot of times, influences our attitudes towards death. Some fear death, and others look forward to death and accept it. So religion has a huge impact. Sometimes people believe in life after death, or that they'll be reunited with a loved one. The possibility of reincarnation, coming back as something else, punishment for their sins, or that there may not be an afterlife. This can all influence how we feel about death. Another thing is the age. So all children view death as temporary, that you might get shot, but you're coming back. When we move into adulthood, we develop fears of pain and suffering, dying alone, separation from loved ones. And then the elderly, they generally have few fears, but they still go through the grieving process. An individual resident's reaction to death could be acceptance, or they could be resigned to death as imminent. They could be open and receptive, communicate about uncertainties. They may be fearful or angry. They may be anxious and hostile or despairing, or they may become very thoughtful and meditative. So some of the physical signs of impending death, let's talk about the sensory functions and the changes. So the vision. We may see that our residents have blurred and failing vision more so than normal. They have increased secretions in the corner of the eye. There may be no movement. They may stare, or they may have an unfocused eye, which means that they may just have a gaze. In these cases, let's reduce glare and keep the room lighting very low. So another sensory function that may change is speech. It may become very difficult and hard to understand, and oftentimes our residents are unable to speak. So a care point is, do not expect an answer. Observe body language of your resident and anticipate their possible needs. Another sensory function that shows impending death is hearing. So this is of particular note that hearing is the last sensory function to be lost. So you need to be very careful what you say. So talking about touch, their sense of touch is diminished. So we need to make sure that our touch is gentle and that we provide excellent skin care. So when we go into circulation and muscle tone, loss of movement and muscle tone and feeling, the body may become limp, the jaw may actually drop, and the mouth may stay partly open. So circulation fails, heat is lost from the body. Mottling, which is kind of a bluish, purplish tinge to the skin, which may look bruised, or spotting or blotching of the skin, is caused by poor circulation. So the hands and the feet become cold to the touch, and the face may become pale or gray and mottled. Another interesting fact is that perspiration may increase, and that is called diaphoresis. That is the medical term for perspiration increasing. With our patients, we may see change in vital signs. The blood pressure will actually decrease, and the pulse may become abnormally slow or rapid or irregular. Temperature can rise or go below normal, and respirations become slow and irregular, alternating with rapid, shallow respirations, which is called Cheyne-Stokes respirations. So one of the other changes is you can also see agonal respirations, which we call fish out of water breathing, or a rattling or a gurgling sound, which is referred to as the death rattle. When someone has alterations in breathing, always remember to elevate the HOB, which is the head of the bed, to improve and to facilitate breathing. So another impending sign of death are changes in bowel and bladder, which is urinary and anal incontinence. Yes, our patients do evacuate urine and stool from their bodies. We see this because of decreased peristalsis, abdominal distension is possible, and a release of flatus, which is gas. So another sign of impending death is a lot of times our patients have decreased pain, or they may not tell you they have pain. These are two pain scales. One of them is the FACES, and then another one is a verbal pain scale. So you can actually look at your patient's resident's face and see what level of pain they may potentially be at. Another sign of impending death is a decreased intake of food and fluid. At this point, we would need to modify the diet and not force feed our residents, but encourage fluid. We may also see some disorientation and confusion and possible loss of consciousness. So as we talk about caring for the dying resident, let's talk about the care of the nose and the mouth. We need to make sure that we give mouth care often. If our resident is unconscious, we're going to provide that every 2 hours. Then we will apply lubricant such as lip balm to the lips and the nose. And of note, olive oil is a good lubricant for the lips versus Vaseline. So when we care for the skin, we're going to give bed baths and incontinence care as needed. Bathe perspiring residents often, keep their skin clean and dry, change the sheets and their clothes so that they're not laying in things that are cold and wet. And we're going to keep the sheets wrinkle free. We do not want to increase any skin breakdown. So we'll reposition often as possible and use supportive devices. We will reposition at least every 2 hours or as needed. Promote comfort, observe for signs of pain, and let someone know about those signs of pain. Frequent changes of position and back massage and body alignment are also good for our residents. Elevate the head of the bed to facilitate their breathing. Control the environment. Place the residents' favorite objects and photographs where they can see them. Provide appropriately lit and well-ventilated room without smell, and put a call bell in reach even if they are unresponsive. How do we control the environment? So personal items in the environment, pictures, mementos, cards, flowers, religious objects provide comfort and reassurance. Treat religious objects with care and respect, things such as medals, pictures, statues, and Bibles, and encourage families and friends to be included. These things are a source of strength and comfort, so we need to make sure that we're all open and receptive. And as a nurse aide, you need to make sure that you know your own feelings about death and don't project your feelings onto residents. Make sure that you're empathetic, calm and efficient, use a normal tone of voice, use good listening skills, and are non-judgmental. Offer comfort measures such as drinks and food, chairs and blankets within the facility's policy. Make sure you utilize good communication skills. Listen and provide understanding throughout the grief and loss stages, and answer any questions or refer them to a supervisor. Be available for support. Use touch as appropriate to support family and friends. Be courteous and considerate, and also make sure that you respect the right to privacy. Let family assist with care if they want to and where it is appropriate. So spiritual support, we always allow the clergy, the priest, the rabbi, the minister, or other clergy may be contacted at the request of the resident or the family. Privacy needs to be provided when this is called for. You may not agree with the person's religion, but it is your job to ensure that they have the appropriate clergy support that they need and spiritual support. So support their religious practices even if it's different from yours. Listen respectfully to religious and spiritual beliefs and participate in religious practices if you're asked and you find it acceptable. So let's talk about hospice care. So hospice care is offered in hospitals and extended care facilities, and it's often in special facilities, which is a freestanding building, or it can be in an individual's home. Continuing care is provided by a team of healthcare professionals, and it's designed for residents with terminal illnesses. In the sense of hospice care, there is an acceptance of death as imminent, which means it's 6 months or less, and it assures that the individual dies with dignity and comfort, not concerned with cure or life-saving procedures, but the emphasis is on pain relief. Trained volunteers and professionals make regular visits. So they also provide counseling for individual and family that can be emotional, psychological, spiritual, financial, or bereavement. Families are included in all aspects of care and as it's desired to be included. So after the patient has passed away, we will do post-mortem care of the body. Post means after, death is mortem, so post-mortem care. Post-mortem care is done to prevent discoloration and skin damage, maintain a good appearance of the body, identify the body and prepare it for transportation, be that to a facility for the funeral, or position the body in normal alignment, and arrange for the time for the family to view the body. Begin care when you're asked to. Treat the body to privacy and respect and gentleness, and give care before rigor mortis sets in, which is basically tissue hardening. And we will now perform postmortem care.